Are you over 70 and facing another round of checkups? Stop. Before you go in for that next routine scan or test, ask yourself, is this test going to help me or just empty my wallet and land me in the hospital? Today, we're exposing the 5 most common medical tests that doctors order. Not because they're essential, but because they often lead to highly profitable, yet potentially dangerous, follow-up procedures. We'll show you which bone scan, heart test, and even common cancer screening may be doing more harm than good, and the simple, safer alternatives you can ask for right now. Don't let fear push you into a treatment you don't need. Stay with us, because we're revealing the single worst test that experts say could actually be causing up to 5% of all cancers. In the landscape of modern medicine, there is a pervasive and often unchallenged belief that increased surveillance through routine diagnostic testing is the ultimate pathway to longevity and health security. For individuals over the age of 70, however, this belief requires critical reevaluation. While early detection is undeniably beneficial in many younger populations, the risk-benefit ratio of common screening tests often shifts dramatically in later life. As the video data suggests, a significant portion of medical tests conducted on seniors, potentially up to 37%, may lead to unnecessary interventions, adverse drug events, or complications that ultimately decrease rather than enhance quality of life. This phenomenon, often referred to as overdiagnosis and overtreatment, occurs when screening detects conditions that are either slow-growing, benign, or unlikely to cause symptoms or death within the patient's remaining lifespan. The elderly often have multiple comorbidities, making them more vulnerable to the side effects of diagnostic procedures, the stress of preparation, and the risks associated with general anesthesia or sedation. Therefore, this chapter sets the foundation for understanding that for the senior population, the indiscriminate pursuit of more data through routine screening may paradoxically introduce unnecessary harm and diminish well-being. The goal shifts from maximizing detection at all costs to judiciously selecting tests based on individual health status, life expectancy, and a clear understanding of the potential cascade of harm that can follow an ambiguous or false positive result. The unintended consequence of routine screening is the initiation of the false alarm cascade, a sequence of events where a non-specific or false positive finding on an initial test leads to progressively more invasive, costly, and anxiety-provoking follow-up procedures. This cascade is particularly dangerous for seniors. For instance, an ambiguous spot on a full-body CT scan, Chapter 5, may be a harmless, age-related calcification, yet it necessitates immediate referral to a specialist, a PET scan, and potentially an invasive needle biopsy. Similarly, a cardiac stress test, Chapter 7, may yield an inconclusive result due to age-related physiological changes, pushing the patient toward an unnecessary catheterization and stent placement. This sequence subjects the senior to radiation exposure, risk of infection, and exposure to contrast dyes that can impair kidney function. Furthermore, the psychological toll, the weeks spent fearing a cancer diagnosis or a major cardiac event, significantly impacts mental health and quality of life, even if the final diagnosis is benign. This chapter will meticulously detail how this diagnostic momentum takes hold, illustrating how medical practice sometimes prioritizes eliminating diagnostic ambiguity over the primary mandate of doing no harm, particularly when dealing with non-symptomatic, older individuals. To understand the scope of the problem, a detailed analysis of the epidemiology of overdiagnosis in the geriatric population is warranted. We examine peer-reviewed data and clinical guidelines suggesting that current screening practices frequently exceed the point of clinical utility for the elderly. Key findings from major journals such as those cited in the video, e.g. studies in JAMA Internal Medicine and the American Geriatric Society, indicate that the ratio of serious complications to lives saved is highly unfavorable for several common screenings in the very old. For example, studies assessing colonoscopy in individuals over 75 demonstrate a striking risk-to-benefit imbalance, with a far greater incidence of perforation, bleeding, and adverse sedation events compared to cancer prevention benefits within a limited life expectancy. This chapter will present the available statistical evidence in a clear, responsible manner, using cautious language to highlight areas where the medical benefit of continuing screening for a serious disease does not outweigh the cumulative risk of the screening and subsequent diagnostic workup. The focus is on establishing a data-driven rationale for de-implementing certain screening practices in the context of individualized, patient-centered care. Patient empowerment hinges on the ability to engage in shared decision-making, especially concerning invasive or potentially harmful medical interventions. For seniors, the single most critical phrase to master is, "If this test finds something, how will the results change my current treatment plan? And what are the known risks of that next step?" This chapter advocates for a methodical, risk-aware approach to consenting to a test. It encourages seniors to explore the spectrum of possible outcomes, the probability of a false positive, the nature of the immediate follow-up procedure, e.g., radiation dose, sedation, recovery time, and the evidence supporting the ultimate intervention, e.g., is a stent placement actually proven to extend life for an asymptomatic patient? By framing the decision in terms of the entire diagnostic and therapeutic trajectory, patients can move beyond passive compliance and become active participants in mitigating the risks of the false alarm cascade. This process promotes a rational assessment of whether the anxiety and potential morbidity associated with the investigation are justified by a demonstrable likelihood of improved health outcomes. The widespread marketing of executive health or preventive full-body CT scans as a comprehensive cancer detection tool warrants deep skepticism, particularly for the over 70 population. This chapter will meticulously dissect the dual threat posed by this specific screening. First is the significant radiation exposure, which, as studies indicate, can deliver the equivalent of hundreds of chest X-rays, accumulating to a dose potentially responsible for inducing up to 5% of all cancers nationally. This concept of iatrogenic, medically caused cancer risk from a preventive test is fundamentally counterintuitive and profoundly concerning. Second is the high probability of incidental findings, small, clinically insignificant lesions, nodules, cysts, calcifications that are statistically guaranteed to appear in an older body. The ensuing workup for these pseudo-diseases introduces all the risks of the false alarm cascade without providing any proven mortality benefit. The narrative will strictly adhere to evidence-based advice from bodies like the American College of Radiology, which unequivocally cautions against the use of whole-body CT scans for general screening in asymptomatic adults. Colonoscopy remains an indispensable tool for colorectal cancer screening in middle age, but its risk profile in patients over 75 shifts to an area of significant caution. This chapter examines the ethical and clinical considerations for de-implementation. We focus specifically on the data demonstrating that for very old individuals, especially those with a limited life expectancy or complex medical histories, the procedural risks often exceed the life-saving benefit. The analysis will detail the specific dangers, the harsh bowel preparation that can cause severe electrolyte imbalance and dehydration, the increased vulnerability to sedation-related neurocognitive issues, and the heightened risk of serious complications like bowel perforation and post-polypectomy bleeding. Referencing the JAMA internal medicine study cited in the video, we highlight the reported 10.1 imbalance where complications may outnumber lives saved. The discussion emphasizes that screening should not be an automatic reflex, but a highly personalized decision, acknowledging that for many in this demographic, less invasive, lower-risk surveillance methods may be the superior choice. Cardiac stress testing, whether performed via exercise or pharmacologic simulation, is intended to detect myocardial ischemia, but its application in the mildly symptomatic or asymptomatic senior over 70 is frequently problematic. This chapter will focus on the high false positive rate, which in this age group can approach or exceed 40%. Physiological changes in the elderly, such as age-related ECG abnormalities or limited exercise tolerance due to orthopedic issues, can easily lead to non-specific test results. Critically, These ambiguous results often serve as the trigger for invasive coronary angiography and subsequent percutaneous coronary intervention, PCI, or stenting. We reference major clinical trials showing that for stable, asymptomatic patients, stenting does not improve long-term survival or reduce the risk of future myocardial infarction when compared to optimal medical therapy. The discussion stresses that unnecessary PCI exposes the senior to the risks of arterial access, radiation, and the nephrotoxicity of contrast dyes, without providing a demonstrable survival benefit, thus illustrating a profound case of overtreatment. The increasing utilization of brain magnetic resonance imaging, MRI, in response to subjective, mild memory complaints in the elderly, often yields findings that are normal in the context of aging, but are misinterpreted as pathological. This chapter analyzes the emotional and clinical fallout of this practice. MRI scans in individuals over 70 commonly reveal mild cerebral atrophy, shrinkage, or small white matter hyperintensities, spots, that are simply a product of normal vascular aging and are not necessarily indicative of progressive dementia. When these common benign findings are reported, they can generate intense distress, anxiety, and a self-fulfilling prophecy of cognitive decline, nocebo effect, as the patient may prematurely withdraw from mentally stimulating activities. Furthermore, the scan can prompt unnecessary and often invasive follow-up investigations, such as lumbar punctures, spinal taps, or even exploratory biopsies, searching for a reversible cause that rarely exists. The chapter argues that a simple, paper-based cognitive screening assessment is the appropriate, low-risk initial diagnostic step, reserving the high-resolution, high-anxiety MRI for cases involving sudden, severe, or rapidly progressive neurological decline. The DEXA scan, or dual energy X-ray absorptiometry, is a tool for measuring bone mineral density, BMD, and is critical for high-risk individuals. However, for the average non-falling senior over 70, the findings often reflect the natural expected process of age-related bone loss, frequently resulting in a diagnosis of osteopenia, mild bone reduction. This chapter highlights the danger of diagnosing and treating this normal aging phenomenon. The principal concern is the overprescription of bisphosphonate medications in response to a T-score that indicates mild bone loss. While these drugs are effective in reducing fracture risk in high-risk patients with established osteoporosis, their use in patients with only mild osteopenia offers a marginal fracture reduction, less than 1%, and exposes them to serious, albeit rare, adverse effects. These include osteonecrosis of the jaw, ONJ, and atypical femur fractures, complications that are significantly more detrimental than the initially detected mild bone loss. The narrative advocates for adopting a functional movement-based assessment, fall history, gait, balance, over a purely structural number-based diagnosis in this population. Having established the risks associated with pharmaceutical intervention for mild osteopenia, this chapter pivots to evidence-based, low-risk, non-pharmacologic strategies for fracture prevention. The discussion is grounded in the principle that fall prevention and functional strength are far more critical than bone density scores alone for preventing debilitating fractures. Key strategies include the optimization of vitamin D and calcium intake through dietary sources and measured supplementation, the implementation of supervised weight-bearing resistance training, e.g., resistance bands, light weights, to promote muscle strength and bone remodeling, and specialized balance exercises, e.g., Tai Chi, proven to reduce the risk of falling, which is the primary driver of fracture risk. Studies cited will emphasize that these comprehensive lifestyle changes have been documented to reduce fracture incidence by a more substantial margin, over 20%, than many medications in the low-risk elderly population, validating this approach as the preferred first-line intervention. In contrast to the high-cost and high-anxiety brain MRI, this chapter details the clinical utility and advantages of standardized, paper-based cognitive screening tools, e.g. the MiniCog, MOSIE, or SLUMS exam, as the appropriate initial assessment for memory complaints. These brief, validated tests evaluate various cognitive domains, including orientation, recall, attention, and executive function. providing a quantitative, objective baseline that helps distinguish between benign, age-related forgetfulness and a genuine, concerning level of cognitive impairment. The critical advantages for the senior population are zero cost, no exposure to radiation or sedation, and immediate, low-stress feedback. A normal score on a validated screening test can effectively reassure a concerned patient, de-escalating the need for further, often unnecessary high-level imaging, thereby preventing the initiation of the false alarm cascade rooted in anxiety. This chapter proposes that the resting 12-lead electrocardiogram, EKG, ECG, often provides sufficient low-risk information about underlying heart health, making it a preferable initial diagnostic tool over the invasive stress test for many asymptomatic seniors. The EKG is a non-invasive procedure that quickly assesses the heart's electrical activity, providing vital information about rhythm disturbances, e.g. atrial fibrillation, potential signs of prior silent myocardial injury, or conduction system disease. While it does not directly detect blocked arteries, a normal resting EKG in a patient without exertional symptoms provides a high degree of reassurance and is far less likely to generate a false positive result that leads to an unnecessary invasive workup. The EKG represents a conservative, symptom-driven approach to cardiac surveillance that respects the senior's vulnerability to over-testing. For the low-risk senior over 75, the fecal immunochemical test, FET, offers an efficacious and significantly safer alternative to screening colonoscopy. This chapter thoroughly explains the mechanism and clinical advantages of the FIT test, which specifically detects hidden blood in the stool, an indicator of advanced polyps or colorectal cancer. The critical benefit is the complete absence of the morbidity associated with colonoscopy. No bowel preparation, no sedation risk, and no risk of perforation. The FIT test is performed at home, is cost-effective, and maintains a high sensitivity for clinically significant cancers. The strategy involves a shift from high-risk, low-frequency, invasive screening, colonoscopy, to low-risk, high-frequency, non-invasive surveillance, annual FIT. This approach aligns with the principle of reducing iatrogenic risk, while still capturing the vast majority of rapidly developing or symptomatic malignancies in the very elderly. This chapter delineates the precise clinical circumstances under which advanced imaging is not only justified but medically mandatory for the senior patient. The core principle is that imaging should be targeted, focused on a specific organ or system, and symptom-driven, necessitated by clear, unexplained signs of pathology, rather than performed as a generalized preventative measure. Examples of appropriate indications include unexplained, significant weight loss, new onset of neurological deficits, e.g. sudden paralysis or speech change, or coughing up blood. In these defined scenarios, the potential benefit of identifying and treating a serious symptomatic disease unequivocally outweighs the risk of the scan. This approach contrasts sharply with the shotgun approach of a full-body CT, reinforcing the concept that medical resources and patient risk should be mobilized only when there is a clear diagnostic question guided by clinical evidence. Navigating the healthcare system requires that seniors have clinicians who prioritize evidence-based, personalized care over adherence to generalized screening metrics. This chapter empowers patients to recognize and address a potential breakdown in the clinician-patient relationship, particularly when a doctor insists on unnecessary testing without engaging in shared decision-making. Key indicators of a practitioner who may be over-testing include automatic referral for every age-based screening test, regardless of comorbidity, dismissing patient concerns about procedural risks, and a failure to discuss treatment alternatives, e.g., lifestyle modifications. Practical advice is provided on finding physicians certified in geriatric medicine who are specifically trained to manage complex, multi-system diseases and who understand the unique risk-benefit calculus for the very old. The focus is on finding a partner in health who practices de-prescribing and de-screening when clinically appropriate. The psychological burden of the false alarm cascade can be as debilitating as the physical risks of the procedures themselves. This chapter focuses on evidence-based strategies to manage the intense anxiety, distress, and potential depression that frequently follow an ambiguous or non-specific test result, e.g., tiny nodule found, mild white matter change. The anti-anxiety toolkit includes structured techniques such as immediate consultation with a specialist for a definitive second opinion, utilizing mindfulness and controlled breathing exercises to manage uncertainty, setting a fixed timeline for reevaluation rather than rushing into immediate, invasive procedures, and actively engaging in mentally and socially stimulating activities to counteract fear-induced withdrawal. The emphasis is on neutralizing the panic, which can otherwise pressure the senior into premature and poorly considered interventions. This chapter provides a step-by-step framework for halting the diagnostic momentum once a potentially misleading or false positive result has been generated. When a vague abnormality is identified, e.g., an incidental finding on an imaging report, the immediate action should be a structured period of watchful waiting or follow-up with the least invasive method possible. The steps include consulting with the primary care provider to understand the statistical probability of the finding being clinically significant, obtaining a direct copy of the imaging report and pathology results, and seeking non-surgical specialist consultation to weigh the risks of intervention against the risks of non-intervention. The goal is to avoid the rapid progression into the pipeline of procedures, biopsy, catheterization, surgery, by inserting a mandatory, evidence-based pause for thoughtful deliberation. Advanced diagnostic procedures often rely on intravenous contrast agents, dyes, and sedative medications, both of which pose distinct and elevated risks for the elderly. This chapter meticulously outlines these specific pharmacological and physiological vulnerabilities. Iodinated contrast dyes used in CT scans and angiograms carry a risk of contrast-induced nephropathy, kidney injury, which can be particularly damaging to seniors who already have age-related decline in renal function. Similarly, even light sedation used for procedures like colonoscopy or biopsies can lead to post-procedural neurocognitive changes, delirium, or prolonged functional decline in older patients, especially those with pre-existing cognitive vulnerability. The chapter advocates for proactive screening of kidney function before any procedure involving contrast, and for the use of the lowest effective dose of sedation, with continuous monitoring of neurocognitive status. Moving beyond a reactive test-based approach, this chapter guides the reader in constructing a proactive, symptom-driven health management plan. This involves establishing a clear, documented baseline of functional status, mobility, independence, energy levels, and prioritizing maintenance of that function over achieving optimal numbers on lab reports. The personalized plan focuses on annual review of medications, de-prescribing when possible, routine screening only for conditions with high and demonstrated utility for the individual, e.g., flu shots, targeted cancer screening based on family history, and actively reporting changes in functional status, rather than simply reporting mild symptoms during an annual physical. The emphasis is on managing the health journey based on how the patient feels and functions, rather than reacting to every numerical deviation from a young adult standard. The concluding chapter summarizes the paradigm shift essential for safe and successful aging, embracing the less is more philosophy in medical care. This involves conscious rejection of aggressive screening practices that have outlived their clinical utility and a firm commitment to non-invasive, low-risk interventions. The chapter re-emphasizes that true longevity and quality of life are not found in the absence of all disease markers, but in the preservation of function, the mitigation of risk, and the avoidance of iatrogenic harm. By prioritizing lifestyle, mental wellness, and selective judicious diagnostic testing, seniors can reclaim ownership of their health narratives, fostering a relationship with medicine that is cooperative, cautious, and ultimately focused on maximizing good years, not just maximizing diagnostic data.